So yeah, I presented a lot of data today because there's such exciting results that came out from ASCO 2022 this year. I first presented Destiny Breast 04 study, which showed a significant improvement in progression-free survival and overall survival for HR positive HER2 low metastatic breast cancer in a subset analysis or exploratory analysis in the HR negative, HER2 low metastatic breast cancer patients. We did also see a benefit improvement in PFS and also OS. Even though it's a small group of patients, it's very impressive. So we're very excited that we now have this new FDA-approved therapy that targets HER2 low, the first ever, and we are hoping that we can expand on this landscape of novel ADCs in order to provide improved cure rates for earlier stage breast cancer, as well as first an earlier line setting for metastatic breast cancer. Then I presented the study with Tropics 002 trial where it was looking at another ADCs which targets TROP2, sacituzumab in heavily pretreated endocrine refractory HR positive HER2 negative breast cancer in the metastatic setting. And in that study, we also saw an improvement in progression-free survival and also improvement in the progression-free survival rate at 6, 9, and 12 months. Interestingly, we also saw an improvement in quality of life for patients who are treated with sacituzumab compared to chemotherapy. So with that, we now have another choice for our patients in terms of having another treatment line available for them using sacituzumab. Then next, I presented the Paloma-2 overall survival data, where unfortunately, disappointingly, we saw that there is no a significant benefit by using palbociclib with letrozole compared to letrozole in the first-line setting for patients with HR positive, HER2 negative metastatic breast cancer. It's unclear to us why there is a lack of overall survival benefit, even though the progression-free survival data was excellent. Some of the reasoning behind the lack of overall survival benefit I have kind of postulated and reviewed, which include potentially a higher percentage of patients with disease-free interval after adjuvant therapy, potentially also the underpowered study with underestimation of the median overall survival for both arms of the study. And then there's also that question remains of whether or not all CDK4/6 inhibitors are created equal. So we're still waiting for the overall survival data from MONARCH-3, which is going to be presented at ESMO in a few weeks. So I'm excited to see what the data pans out, and in terms of for clinical practice, I would say right now for the next few weeks, I'll be using ribociclib for our patients who need to start on first-line therapy for metastatic breast cancer if they don't have any comorbidities or concurrent medications that will contradict ribociclib. But yeah, I would say for other patients, I would still use palbociclib or abemaciclib first line. Then I presented another study looking at the use of denosumab in the adjuvant setting for patients with early breast cancer, and the secondary endpoint of DFS, or disease-free survival. Disease-free survival. And then in that study, it was based off of the ABCSG18 study, where denosumab was used versus placebo in the adjuvant setting. And as we know, the primary endpoint, which is the time to first fracture that reached a significant difference, and then this secondary endpoint with DFS and also bone met recurrence survival and also the overall survival also was significant. So with improvement towards using denosumab. So based off of this, I would say denosumab adjuvantly can be considered and used. However, personally, I think there is definitely more data using Zometa adjuvantly compared to denosumab, and I would still prefer using Zometa over zoledronic acid over denosumab. The study that I decided to look at next is the triple negative breast cancer in the early setting. Analysis that were pre-planned looking at event-free survival or EFS based off of RCB, residual cancer burden, and what that found, and that was done within the Keynote 522 study. So in Keynote 522, which is a study looking at chemotherapy plus pembrolizumab neoadjuvantly versus chemotherapy neoadjuvantly alone, followed by surgery and then adjuvant pembrolizumab. That study reached their primary endpoint, which is PFS, with an improvement of PFS of absolute improvement of 13%, and then also the event-free survival. It showed a significant event-free survival improvement. So the question remains, who will actually benefit from pembrolizumab? And in that study, we saw that with the addition of pembrolizumab to chemotherapy, the residual cancer burden was reduced. So much higher percentage of patients have RCB 0, 1, and less patients have RCB 2 and 3. What's interesting, however, is when you compare the subset of patients who reach RCB 0 and 1, the difference or the absolute benefit of addition of pembrolizumab is very small. It was not very significant. However, for patients with higher residual burden, such as RCB2, there is a significant improvement in event-free survival for those patients. So I think in our mind now, we still think that adding pembrolizumab until we know how to select our patients, adding pembrolizumab to neoadjuvant chemotherapy will be standard of care. And there are going to be studies looking into whether or not adjuvant pembrolizumab is necessary for patients with a pathologic complete response. And this question is going to be addressed in the SWOG 1418 study. And then also, how are we going to be able to select patients before treatment to give pembrolizumab? Who is going to reach the RCB 0 or pass CR without pembrolizumab is a question without exposing them to potential immunotherapy-related side effects. So yeah, so I think this is exciting, and the next study I decided to cover is the HER3 breast cancer. So in the era of novel ADCs, we are seeing more and more different types of targets that one can link to chemotherapy, and the HER3 is one of the potential targets in breast cancer that we can target. So HER3 overexpressors and HER3 low breast cancer patients were enrolled from all subtypes onto the HER3 ADC study, the phase 1-2 study using patritumab, deruxtecan, and it was shown to have a very nice overall response rate of about 30% across all the subgroups, and then also duration of response somewhere between 6 to 8 months. So I think it's pretty respectable. It may provide us another treatment options for patients who run out of other options. So I'm very happy to see that we are really in breast cancer entering the the era of antibody drug conjugate or ADCs, and they can, different targets or different antibodies, and also potentially other ways to really deliver the chemotherapy, like using nanoparticles, can really lead us to better outcomes for our patients, not just in overall survival, but potentially cure rates, so we don't have to really face stage 4 breast cancer for most majority of our patients in the future. So with that, I'm very happy to see some very excellent study from ESCO 2022. I wish I can cover more abstracts, and there are a lot of them. They were excellent, but these are the abstracts I think it will be, currently practice changing and also potentially practice changing in the future.